management has undergone a revolutionary change over the last 10 years. And revolutionary is not metaphorically speaking, it is in real sense that there has been a sea change in the management of heart failure patients over the last decade. And that is dependent on better understanding of pathophysiology of the heart failure. Heart failure, as you know, is not a single disease entity. It is basically the final common pathway for most of the cardiac problems, whether they are myocardial, they are endocardial, or they are pericardial. If they have been chronic, long-lasting, they end up in heart failure. So heart failure basically is a syndrome. It's the final common pathway, end stage of cardiac problems. So therefore, you cannot treat such a disease with single entity. There cannot be a standardized form of management that will fit all patients with heart failure. It has to be individualized. It has to depend on the underlying cause. So therefore, when we are talking about heart failure, we have to keep that thing in mind, that we are not going to talk about one particular patient, but a syndrome, and therefore the principles that I'll be talking about will be applicable to the patients, for most of the patients who have heart failure. But obviously there will be patients who've got a special form of underlying disease, such as pericardial problem. So obviously they will not fit in nicely to the management plan that I'll be talking about today. For example, patients with constrictive pericarditis is going to have a heart failure. So you cannot have the same form of treatment I'm going to talk about as a patient who's had end-stage ischemic cardiomyopathy or idiopathic dilated cardiomyopathy. So when we talk about these patients, we basically take into consideration that we are talking about a patient who is a prototype of most of the patients who present with heart failure. So this is the pretext that I'm going to build on in the next 40 to 45 minutes. I'll try to make this one as an interactive so that we are taking part in the management plan of heart failure patients rather than just a monologue talking to you just on my own. Right. As I said, just without going into the details of any one of those, because that will defeat the purpose of talking on the most important aspect of the heart failure. So we're just going to restrict ourselves, saying that the myocardial diseases, endocardial diseases such as valvular heart diseases, and the pericardial diseases, they all end up in heart failure. You know the examples. For example, myocardial disease. The commonest myocardial disease that we have nowadays is ischemic heart disease that damages the myocardium. So when the myocardium is damaged, it's a weak pump, and the weak pump leads to heart failure. So another myocardial problem is myocarditis. If the myocarditis is severe, viral myocarditis or toxic myocarditis, that leads to flabby muscles of the heart, and the flabby muscle of the heart is again a weak pump, and that leads to systolic pump failure or heart failure. You getting that one? For example, severe aortic stenosis. If it's a severe aortic stenosis, there's a lack of forward cardiac output. It's a back pressure. So the myocardium is under tremendous stress, and that leads to heart failure in due course. And not only that it's under stress, but because of the fibrotic changes that happen in these patients. Over a period of time, the muscle becomes hypertrophied, and hypertrophied muscle is an abnormal muscle up to a point, and therefore it is filled with fibrous tissue, leading to fibrotic myocardium, and that is not a proper pump. So therefore it leads to heart failure. Heart disease that leads to heart failure is mitral stenosis. Although there's no problem with the myocardium here, the myocardium in itself is not the primary seat of abnormality. It is the mitral valve that leads to the back pressure, and therefore leads to pulmonary congestion, and signs of pulmonary congestion are basically the same as signs of left ventricular failure. I just want to make a distinction here that pulmonary edema is not synonymous with left ventricular failure. although most of the time the pulmonary edema is due to left ventricular abnormality. But in case of mitral stenosis, it's the stenotic problem between the left atrium and the left ventricle that leads to the gradient between the left ventricle and left atrium and back pressure into the pulmonary circulation, leading to pulmonary congestion and signs of pulmonary edema, but not left ventricular failure. So pulmonary congestion, as we understand it, is not always due to left ventricular failure. It can be due to valvular problems. And the treatment of that will be separate. What is the treatment? What's the basic principle of treatment of mitral stenosis? While we are just talking about mitral stenosis, because I won't have a time to go into that one in detail. So just while we are on that, mitral stenosis. If a patient of mitral stenosis comes to your practice, how are you going to treat the mitral stenosis? How? Diuretics. Positive inotropic support in patients with mitral stenosis. The heart pump is there. It's not failure of the heart pump. The problem is the transmitral gradient leading to pulmonary congestion. And that gradient is dependent on two important factors. Fixed flow through the mitral stenosis is the fixed obstruction. The mitral valve is normally 4 centimeter to 6 centimeter wide. It's a big valve. It's not a small valve. The aortic valve is much smaller, half the size of mitral. And the tricuspid is even bigger. So 4 to 6 centimeter square is about that big. Right. So 4 to 6 centimeter, when it constricts, it becomes narrow, up to 1 centimeter, less than 1 centimeter. Now the forward flow between the left atrium and the left ventricle is reduced. Now, what during the cardiac cycle, what portion of the cardiac cycle does the filling take place? Diastole. So if there is a fixed stenosis now, you can only get so much blood, so you cannot change the ring. Now, what variable do you have at your disposal to improve the flow from the left atrium to the left ventricle? Prolonged diastole. Prolong the diastole, because diastole is the period during which the flow is going to happen. So by prolonging diastole, you, even if the valve is stenosed, you can hope to get most blood through. How would you do that? How do you prolong diastole? Control the heart rate. And the commonest arrhythmia, if patients got mitral stenosis, the commonest arrhythmia is atrial fibrillation. A doctor who cannot control atrial fibrillation and mitral stenosis can never treat heart failure. The essence of medical management of mitral stenosis is control of the heart rate. Control the heart rate, and you control pulmonary congestion in patients with mitral stenosis. And you do that with digoxin and maybe, if needed, with beta blockers. So combination of digoxin and beta blockers is an essential part of management of mitral stenosis patients. And if the patient is going at a steady state of 60, 70 or 80 beats per minute, you can bet your bottom dollar the patient will not go into heart failure. And the reason for most of the mitral stenotic patients going into pulmonary congestion during pregnancy is the tachycardia. The tachycardia that happens during pregnancy tips the balance in favor of pulmonary congestion by abbreviating, shortening the diastole, because tachycardia basically occurs at the expense of diastole. So therefore, the corollary is that the medical management of mitral stenosis is basically aimed at controlling heart rate, and in particular atrial fibrillation. So therefore, the management of that kind of heart failure will be, although it's a heart failure, but will be totally different from what I'm going to talk about next. Therefore, remember, when we are talking about heart failure, we're talking about a great deal of underlying causes, and the management of that heart failure will be dependent in part on the underlying cause. Pericardial disease. Can you name any pericardial disease that leads to heart failure? Constrictive pericarditis and pericardial tamponade. So pericardial tamponade is a medical emergency. It usually happens in those patients who've got neoplastic disease, commonly neoplastic disease. It can be infective, such as tuberculosis, but tuberculosis leads to gradual accumulation of fluid, whereas neoplastic diseases particularly lead to rapid accumulation of fluid. And it's the rapid accumulation of fluid in the pericardial space that leads to the tamponade, not a slow gradual accumulation. Slow gradual accumulation, you can have up to 2 or 3 liters of fluid in the pericardial space without getting any pericardial tamponade. So by and large, you'll see patients with neoplastic disease who present with pericardial tamponade, raised venous pressure. They will be short of breath, cannot lie down, and the key to the diagnosis is the raised venous pressure. Just have a look at the veins and you'll see the raised venous pressure up to the earlobes. So the patient doesn't have to lie down, it will be just sitting up and you can see the head bobbing there. The fluid level will be up to that level. So patients with pericardial tamponade is an emergency, and commonly underlying diagnosis is CA breast, prostate, CA lung, and lymphoreticular disorders such as lymphoma in the chest. These are the common neoplastic diseases. Next. Now, underlying causes I've just discussed briefly. You know it. I don't have to go into that, such as myocardial, endocardial, valvular, I've already discussed. What are the precipitating factors? This is different from the underlying cause. You have to recognize the precipitating factor. We all know that, but the distinction I'm trying to make, that these are not the underlying cause. Underlying structural disease has to be there before a precipitating cause can tip the balance in favor of heart failure. So this is just a kind of last straw, aakhri dhachka. When the patient is already in the verge, is compromised, compensated, but now something happens and that leads to heart failure, and those are the precipitating factors. So therefore, any patient who's got a cardiac history, is compensated, goes into decompensated stage, has to be looked for these, the list of these causes. The important ones it's not a big list. It's all of us, we know that. So just very briefly, we'll go over that. Pulmonary embolism. Always think of pulmonary embolism in patients with heart failure, because heart failure patients are on diuretics. They are limited in their physical ability. Mostly they are bedbound or chairbound. They have got very little to do. So it encourages the stasis in the legs, and that stasis leads to DVT and pulmonary embolism. So pulmonary embolism is not uncommon in patients with heart failure. I'll tell you a story. I was training in Liverpool, Blackpool, in England, and we had a patient, an elderly, 80-year-old elderly man who was brought in with severe aortic stenosis. My consultant was Dr. Logan. He said that this man, he's not getting dry, so we have to do the angiogram when he's still wet. In other words, he was still in heart failure. We have to do the angiogram because we want to send him for emergency bypass surgery and aortic valve replacement. The patient was on large dose of diuretics. He was on large dose of diuretics and ACE inhibitor, standard anti-failure treatment. And our hypothesis was the patient was in heart failure because of the aortic stenosis, severe aortic stenosis. So therefore, we were increasing the dose of diuretics because he was not getting dry. So by increasing the doses, we got to a point where we took him to the cath lab. I did the angiogram, and after first shot, there was nothing there. It was just a blank screen. The patient expired after the first injection. And a patient with aortic stenosis, if he expires, they don't come back. There's no need to do cardiac resuscitation on these patients because they don't come back. It's just that the ventricle is given up. So their autopsy has to take place. So the patient was sent for autopsy, and I went there. And would you believe that the patient was full of thrombi from his femoral veins up to the mid part of his lungs, both sides? Bilateral severe pulmonary embolism, extensive on both sides, a patient with heart failure. And there was no way we could have treated that with diuretics or anything because he was dry, he was bedbound, dehydrated, and on top of that, we were again pumping in more and more of Lasix without thinking that the patient could have underlying pulmonary embolism. So the pulmonary embolism comorbid condition, not just on its own, but in association with heart failure, is not uncommon. It should be taught and should be treated aggressively, and patients should be investigated with ventilation perfusion scan, and if needed with pulmonary angiography. Nowadays we've got high resolution CT scan. So high resolution CT scan or VQ scan are the investigations of choices in these kind of patients. Sepsis, any sepsis will result in decompensation. So therefore look for sepsis, urinary tract infection, pneumonias, or any sepsis. So anybody who's got a fever or sepsis can go into decompensation if he was already in compensated heart failure. Anemia, you know that. Any anemic patient, and it is not uncommon if you go into hospital practice, believe me, you see hemoglobin as low as 4 grams. 4 grams or 6 grams, patients coming in with hemoglobin of 4 grams and 6 grams and bitterly complaining of angina or heart failure. So treat anemia, and the underlying cause is commonly the gastritis, is bleeding from GI tract because of the aspirin that we normally give to these patients, and that leads to decompensation in these patients. Thyroid dysfunction, again, it has to be, look for thyroid dysfunction in every cardiac patient. It is a good practice to look at the thyroid and say in your own mind, this person has or has not a thyroid dysfunction. It is better to say that in your own mind as a checklist that this person has got thyroid or no thyroid dysfunction, because it is easily diagnosed if you're thinking about it. And if you don't think about it, you're missing a very important and treatable diagnosis in these patients. Arrhythmias. Any patient with compensated heart failure, if he gets into arrhythmias, he will be decompensating. And the commonest arrhythmia in practice is atrial fibrillation, especially in patients with mitral disease, in patients with hypertension, in patients with ischemic heart disease. Any patient who goes into atrial fibrillation, usually that's the turning point in the natural history of that particular patient, heart failure. Another disease you have to think of is HOCM, Hypertrophic Obstructive Cardiomyopathy. And patients with HOCM, if they go into atrial fibrillation, that usually do go into atrial fibrillation in the history of the disease process, natural history of the disease process is it degenerates into atrial fibrillation at some stage, and that is the turning point because you lose that atrial kick. That atrial kick usually gives you about 25% of the cardiac output. So in patients with atrial fibrillation, you lose 25% of the stroke volume, and therefore there's a decompensation of these patients. Another arrhythmia that can give rise to decompensation obviously is ventricular AV dissociation, such as bradyarrhythmias, complete heart block, or ventricular tachycardia. But those are rare except in patients with ischemic hearts. So the common arrhythmia that leads to decompensation is atrial fibrillation, and it should be identified and treated. Associated myocarditis, in rheumatic heart fever, recurrent rheumatic heart fever in patients with rheumatic heart disease can lead to decompensation and therefore heart failure. Important, very important, remember, you are going to see more and more patients with infective endocarditis, in particular prosthetic valve endocarditis, because now there are more cardiac patients out in the community who've got valve replacements. So therefore, valve replacement patients, they are prone to get infections, and those infective endocarditis patients are going to be increasing in the community, and therefore you have to look for that infective endocarditis as cause of heart failure. Anybody with, say, rheumatic heart disease, aortic regurgitation or mitral regurgitation, and he goes into decompensation or she goes into decompensation, think of infective endocarditis. Always get an echo done. And if patient is febrile, waste no time to send the cultures, 3 cultures from 15 minutes apart, and they should send that or send the patient to hospital. Any stress, emotional stress or physical stress, can lead to decompensation, particularly if somebody is already compensated heart failure. Now he has to go, say the wife has died or husband has died. So emotional and physical stress during that time can lead to decompensation. Sometimes there's also non-compliance during that particular time. systemic hypertension can cause, obviously, it's quite obvious, myocardial infarction, especially in elderly people. Anybody who's been compensated or just presenting with heart failure, think of fresh ischemia in elderly patients, because that may be the presenting feature of the myocardial infarction. They may not complain of chest pain. I've seen that. A patient presenting with burning, epigastric burning pain, just sitting there tight, do the ECG and ST elevation and everything. So myocardial ischemia, particularly in the extremes of ages, may present with atypical symptom, and therefore heart failure could be the presenting feature of myocardial infarction in this particular patient subgroup. Pregnancy I've already discussed, in particular in relation to mitral stenosis and myocarditis. So cardiomyopathy patients or pulmonary hypertension patients with congenital heart disease, they poorly tolerate pregnancy. The poorly tolerate pregnancy. In general practice, if somebody's got a history of pulmonary hypertension, strongly advise them against pregnancy because it's got a very high mortality. Pregnancy carries very high mortality, maternal mortality and fetal mortality in patients with pulmonary hypertension. If the pulmonary artery pressure is more than 60 or 70, you must stress against the pregnancy. And in fact, therapeutic abortion should be advised to these patients in the first trimester, if possible. Sorry? Diabetes is another one, but diabetes itself doesn't cause decompensation. It doesn't cause decompensation. It has to go through ischemic heart disease. It has to go through, the pathway that's one of these. But diabetes per se, even if it's 500 uncontrolled, has to either cause cardiomyopathy or it has to go through the ischemic heart disease, myocardial infarction. Both. Systolic is more important nowadays. Right, I think you all know that. It's just a matter of putting it on the piece of paper. Symptoms, dyspnea is most important. In fact, the commonest physical sign or the symptom in heart failure patients is fatigue, tiredness, weakness. But then that's a symptom that everybody is complaining of. So fatigue on its own is so non-specific, but it's so common, and it is the commonest symptom of heart failure patients, fatigue. But out of the important ones, the dyspnea, especially if it's uncharacteristic for the patient. The patient has been doing well previously and now starts finding it difficult to do the same level of physical activity that he's been doing without any problem, say 4 months ago or 6 months ago. That is one of the symptoms of heart failure. Orthopnea and paroxysmal nocturnal dyspnea are well established, we all know that. Chain-stroke respiration is again one of the symptoms and signs of heart failure, and it's not specific, it just is described in books. Signs: raised venous pressure, pulsus alternans obviously is poor ventricle. So those patients who've got poor systolic function, like after myocardial infarction, they would have pulsus alternans. Nobody looks nowadays at pulsus alternans, although we should look for it, because you have to just take the pulse and look for the volume of the pulse in each beat, and you feel that one stroke of the pulse is stronger than the other one. So weak and strong alternans, pulsus alternans, basically signifies poor systolic function. Pulmonary rales is the crepitations in the lung. So basilar crepitations of rales is again feature of pulmonary congestion that is found in patients with heart failure, especially left ventricular failure. Generalized edema is found in patients with heart failure. Congestive hepatomegaly is found, and jaundice, if it's been long-standing, and it causes significant hepatic congestion that leads to jaundice in these patients. Sometimes the jaundice is quite marked. It may be about 3 or 4 or 5 mg% of bilirubin. Next. can I just draw your attention to the fact that I've basically overlooked the forms of heart failure which are described in textbook of cardiology, such as left ventricular heart failure, right ventricular heart failure, forward heart failure, backward heart failure, high output heart failure, low output heart failure, diastolic heart failure, and systolic heart failure. Acute heart failure versus chronic heart failure. There's so many heart failure definitions, but basically, by and large, there are three important ones that we make distinction because they beg different form of management at that particular time. Acute heart failure versus chronic heart failure is definite entity, and it should be basically the diagnosis should be made on that basis. For example, patient who's got a myocardial infarction and after that goes into heart failure straight. Either it is due to severe myocardial damage such as anteroseptal myocardial infarction, or it could be mechanical problems such as VSD or mitral regurgitation due to ruptured chordae tendon. Now this is acute heart failure, and the management of this acute heart failure is totally different from the management of chronic heart failure, which may happen after valvular heart disease or after ischemic heart disease of long-standing duration. Have I made my point clear? That acute heart failure has to be distinguished from chronic heart failure because it begs different form of management. Similarly, systolic and diastolic heart failure. A lot of fuss is created by cardiologists about diastolic heart failure and systolic heart failure. And you'll see the books mentioning this as a separate entity. But practically speaking, from a pragmatist point of view, there isn't anything between diastolic and systolic heart failure except in two clinical situations. A patient has got rip-roaring hypertension, very significant hypertension and hypertensive heart disease with massive left ventricular hypertrophy, or patients with hypertrophic obstructive cardiomyopathy. So those patients have got predominantly diastolic dysfunction. What is diastolic dysfunction? Impaired filling. There is impaired filling of the ventricle, but the systolic function, the pump, is doing very well. So there's no problem with the systolic function, the pumping of the heart. It's relaxation of the ventricle after the pumping that is abnormal. So therefore does not allow adequate amount of flow from the left atrium to the left ventricle. So that is diastolic dysfunction. And the mainstay of diastolic dysfunction is, again, from management point of view, is again the same. You have to give diuretics, you have to give ACE inhibitors, you have to give beta blockers, you have to give, if needed, you have to give digoxin as well. The same as systolic dysfunction. So there isn't much between systolic and diastolic heart failure from management's point of view. So we are going to be practical, and therefore we should not really be thinking and not paying too much attention to diastolic heart failure and systolic heart failure. Remember that. Now, I'll just give you this patient. Let's talk about the management plan. This is 56-year-old man who's got 5-month history of dyspnea in class 3. Class 3 dyspnea, 5 months, is a real patient. He's got paroxysmal nocturnal dyspnea. He's got left bundle branch block of more than 150 milliseconds on ECG. He's in sinus rhythm at heart rate of 60 beats per minute. He's not been taking any medication. This is the first time he's a property dealer, and it comes to your attention. He's got ECG showing left bundle branch block with QRS duration of 150 milliseconds. You remember the normal QRS duration is less than 110 milliseconds. And if it's more than 110 and 120 milliseconds, especially with that left bundle branch block morphology, M morphology, 1 AVL, V5 and V6, we call it left bundle branch block. But here it is 150. So remember, 150 is too big. It's wide, not just wide, but very wide QRS complex. And his echocardiogram showed very poor systolic function and diastolic dysfunction, and he had mitral regurgitation. You'd expect mitral regurgitation in any patient who's got dilated heart. Why? a dilated heart because of the annular dilatation. So there's lack of cusp coaptation because of the annular dilatation that leads to mitral regurgitation or tricuspid regurgitation in any patient is called dilated heart. So it's not a surprising that you have mitral regurgitation or tricuspid regurgitation with dilated ventricles. So he had mitral regurgitation as well, along with left ventricular wall. He underwent coronary angiography, obviously, to rule out any ischemic heart cells, and reassuringly he had normal coronaries. Now, because you'd expect that this man does not have any significant edema. He was only presented with class 3 dyspnea. Class 3 dyspnea, you remember that. Class 1 is the patient can do most of the physical activities. Class 2 is when he can do a big part of his normal activities, but he is not able to do strenuous, such as he cannot climb, say, 50 or 60 stairs, but he can climb 15, 20 stairs, no problem. He can go to mosque, he can walk at his own pace, no problem. Class 3, when he is restricted in his mild to moderate activities, so that he is probably okay around the house, but as soon as he ventures outside the house, he is short of breath and finds it difficult to go around. Class 4 obviously is patient has got shortness of breath or orthopnea. He cannot do almost anything. So class 3 dyspnea this patient had, and he also had paroxysmal nocturnal dyspnea. Now, he is not edematous, so that is one thing that you have to remember, that not every patient with heart failure is going to present with edema. That is the end stage. That's the final common pathway for most of the diseases, especially when it has been long-standing. Now, how would you treat that patient? I was just talking to you before we started off, and somebody said that asked one of the doctors, and he said he qualified in 1979, and at that time the treatment of heart failure was almost nothing. Now, I qualified in 1979, so I thought it was only yesterday we qualified. But look at the treatment options in 1980s of heart failure. This is loop diuretics. Apart from prayers, we had loop diuretics and digoxin. Anything else at that time? Anybody who's qualified before us in 1979 will remember that these were the two therapeutic modalities in the pharmacotherapy that was available to patients for heart failure. I still remember we had a visiting cardiologist from America at that time, and he gave us a lecture. He gave us a lecture about the role of nitrates in heart failure. And one of our professors who was basically moderating said that don't start giving it to the patients with heart failure, because it was such a novel idea at that time that treating patients with heart failure with nitrates was probably something which was just coming into the clinical practice at that time. And the professors at that time obviously were not prepared to accept it as a form of treatment for heart failure. So we had only 2 drugs available for patients with heart failure. And what do we have now? This is therapeutic modalities available, not just on a piece of paper, available. Now, obviously it's going to take a little longer, so in order to make it short and relevant, I'll just talk about the things which are widely available. They are relevant to our today's discussion, and I'll leave the rest of the things at some other time. Now, apart from prayers, would you give aspirin to this patient? I want to make a point about the role of aspirin in heart failure. Yes, please. Can we just pass on the microphone over there, please, so that all of us we can hear that? So, would you give or not give? Give? You would give. In this patient, aspirin, right? Anybody who would not give? You would not give. No. So there are at least few people who would not give. Why would you want to give it to this patient? What does aspirin has got to do with heart failure patient in this particular situation? To prevent clot formation. Does it prevent clot formation? It's antiplatelet. It's not anticoagulant. So antiplatelets is very, got little to do with prevention of clot formation. It's the anticoagulation such as warfarin or heparin that prevent the clot formation. So the antiplatelets are basically drugs that prevent platelet aggregation. And therefore, would you find it useful in this patient? The answer to that is really we don't know. But I think on probability, on the scale of probability, most of the cardiologists now would not prescribe aspirin as a routine to patients without history of underlying ischemic heart disease. Now you have to show that patients got ischemic heart because antiplatelet agents have been shown to be beneficial in patients with ischemic heart disease, such as coronary artery disease, such as stroke. A patient who's got a stroke or history of coronary artery disease, this patient had normal coronary arteries. So we've effectively ruled out underlying ischemic heart disease. So I think there is a data to show that aspirin given routinely to patients with heart failure is probably counterproductive. It is not helpful and should not be prescribed. If nothing else, it probably can do gastric irritation and gastritis. For no good reason, we are going to have that complication from this otherwise useful drug. So therefore, aspirin is probably not indicated in this patient. The corollary is that we should think before we prescribe aspirin or clopidogrel in patients with heart failure that we are treating heart failure due to ischemic heart disease, and that is not due to mitral stenosis or aortic stenosis, or is due to myocarditis or cardiomyopathy or hypertrophic obstructive cardiomyopathy, so on and so forth. So any condition which is non-ischemic should not be treated routinely with aspirin. Clopidogrel, I think the same holds true because it's again antiplatelet agent. Now, if this patient did have a history of stroke, old stroke, say for example 6 months ago he had a history of stroke, would you give these agents or any one of these agents, the top one, number 1 and number 2? Yes. Which one? One or both? Why? Why both? Why not one? Pardon? The clinical evidence, that is evidence-based medicine, tells us that the combination therapy reduces the incidence of stroke by more than 37% compared to monotherapy, which reduces the incidence by 25%. So there is a gain in reduction. There's a gain in the reduction of incidence in patients with stroke and ischemic heart disease with combination therapy. The evidence only at present available up to 9 months to 1 year, and that is the CURE trial. On the CURE trial, they gave combination therapy for up to 9 months and 1 year, and they found that the combination was superior to monotherapy in patients with stroke and ischemic heart disease. So therefore, if a patient with stroke or ischemic heart disease presents to you, combination therapy is better than monotherapy unless there is absolute contraindication. So therefore, that's for those patients who got history of ischemic heart disease or stroke, but not in this particular patient.
What is that absolute?
Hypersensitivity, thrombocytopenia, bleeding complications, bleeding diathesis, or gastric problems. Diuretics, mainstay of the treatment. Mainstay, the cornerstone of treatment in heart failure are the diuretics. And we have a variety of them available, not just the Thaza diuretics, but loop diuretics, and we've got a range of them. So diuretics, they are the cornerstone of treatment for heart failure. Do they prolong life? Of course. So at least there is one, of course, who is not supporting him. The rest, it is only symptomatic improvement. It does not improve the outcome. Symptomatic, quality, improvement in the quality. You remove the symptoms, you basically get rid of excess fluid from the interstitial space, extracellular space, but otherwise it does not improve the lifespan of the patient. There is no data to suggest that diuretics will improve the outcome. There's no data to suggest. So therefore, we titrate the dose to get rid of excess fluid from the patient, but we know that by giving diuretics, we are not improving the lifespan of the patient. Aldactone, I've not put it in diuretics, I've put it separately. Aldactone, who would give aldactone and why? And if not, why not? Hands up for those who will give aldactone. Only very few, so the rest will not give. Why are we not going to give aldactone? Any one of the volunteers? Pardon? Do you want to give or not give? Please. Yeah? Why? Absolutely. Absolutely. And we must remember that. All of us, we must remember that this is a form of diuretic, which is a weak diuretic on its own right, but because it blunts in the pathophysiology of heart failure, there's activation of sympathetic nervous system and this activation of the renin-angiotensin-aldosterone system, RAS. So in order to blunt the overexcited RAS system, this is the antagonist. The spironolactone is the antagonist of aldosterone. And therefore, by taking control of that excessive aldosterone drive in those patients with heart failure, it improves the outcome. It adds life. It adds years to life. It adds years to life of the patient. In fact, the RALS trial, RALES, was a trial that was stopped prematurely because there was more deaths in those patients who were not taking aldosterone. Who were not taking the spironolactone, aldactone. Then in the then in the treatment group. So the treatment group, there were less mortality as compared to the control group. So the investigators, they stopped the trial. It was unethical to carry on because you are seeing that so many people are dying on this side and there's improved survival. So diuretics, loop diuretics, do not improve survival. But aldactone, being a spironolactone as the aldosterone antagonist, it improves survival. And the evidence is in the RALS trial, and the dose given in that trial was 25 milligram OD. So a small dose of aldosterone antagonist, spironolactone, improves the survival in these patients. So remember, unless again there is an absolute contraindication, such as renal failure, advanced renal failure, such as hyperkalemia, such as other condition in which there is a propensity for hyperkalemia, you have to give aldactone as form of therapy, standard therapy to patients with heart failure. Yes, adjunct to loop diuretics, because on its own it's very weak. It will not give you a diuresis that you need for your heart failure patients. Right? So remember, now this is cheap. It improves survival by at least 20%. 20%. And remember, I tell you that this is the therapy, cardiac resynchronization therapy. Is a form of therapy which is basically like a pacemaker. It's a sophisticated form of pacemaker that has got 3 leads, one in the right atrium, one in the right ventricle, and the third one goes into the coronary sinus, which basically is a proxy for left ventricle. And that is called atriobiventricular pacing for heart failure patients. Now it costs you in excess of 700,000. 7 lakh se upar iski कीमत. And it gives you a survival benefit, no survival benefit, just symptomatic improvement. And as compared to 700,000, you've got only 5 rupees tablet, which gives you a 25% improved survival outcome. So this is where evidence-based medicine, we must remember you have to give this aldactone to these patients. ACE inhibitors. We can vote with hands and our feet. Everybody knows about it, so I don't think I need to dwell on that one, except that we have to give them in not just for the sake of barakat ke taur pe nahi dene ki 5 milligram or 1/4 of captopril. That is not the dose. It's the therapeutic doses that are needed. And what are the therapeutic doses? The doses that have been used in the trials. And that is up to 50 milligram 3 times a day of captopril, or 20 milligrams of enalapril, or 20 milligrams of zestril. So all these, lisinopril, all these drugs have to be given up titrated, not straight away starting at the same dose, but up titrated against the patient's symptoms and the blood pressure tolerance. So we are not, the biggest pitfall is that we do give ACE, but we don't give them in proper doses. And unless they are given in proper doses, they are not going to give us the desired outcome.
If BP is 110/70, for example, in left ventricular failure, and then we will give less.
No, as I said, up titrate the dose, because most of the time the fear lies in the heart and the mind of the physician, not with the patient. You will see that if you up titrate the dose, patiently, you will be able to up titrate. I'm not saying everybody will get it, but most of the patients will be able to tolerate therapeutic doses, or as near to the therapeutic dose as possible. We just stop at 1/4 of a tablet captopril and leave the patient on that for donkey's years. Now, beta blockers.
Yes.
Beta blockers.
Start date, but after the patient is dried up.
Yes. This is an important concept. I think everybody is getting to know this thing, but all of us, or most of us, we are still reluctant to prescribe beta blockers in heart failures. And even when we know we have to prescribe it, we are not prescribing at the right time, the right amount, and therefore we're not getting the proper results. Again, to put it in perspective, beta blocker, if given properly to these patients, they reduce the mortality. Risk reduction is again 37% with beta blockers alone. How much? 37% as compared to ACE inhibitors, which is 25%. So beta blockers give you better outcome in these patients as compared to the ACE inhibitor. But because ACE inhibitors are so well marketed by those people, that we have lost sight of the beta blockers. And it's a long history. People who started giving beta blockers, they were so discriminated against. It was a Swedish group. They were so discriminated against that they found it almost impossible to publish their findings in the peer-reviewed journal. It laid there dormant for 10 years before they saw the light of the day. 10 years nobody was willing to publish the findings of a Swedish group who basically showed very conclusively that there was a benefit in patients with heart failure with beta blocker therapy. The idea was so much, not only new, but it was a crazy idea, because everybody thought beta blockers are contraindicated. Now, because of the overstimulation of the sympathetic nervous system, and that basically precedes the stimulation of the renin-angiotensin-aldosterone system. So therefore, in order to blunt the effect of overdrive of SNS, sympathetic nervous system, you give beta blockers inappropriate. Again, you start at a very low dose. For example, carvedilol. Carvedilol has got the longest evidence, the biggest evidence, and it's been there for the longest. So therefore, beta blocker, out of beta blocker, carvedilol or metoprolol or bisoprolol, any one of these three. The trials are for these three. So you take beta blockers such as carvedilol, 3.125 milligram OD for 2 weeks. How long? 2 weeks. Not just every other day or every week. 2 weeks, give that in addition to all the standard therapy, and see if the patient stays compensated. If patient slips into decompensated state, increase the dose of diuretic, not stop it. Don't stop. Once you've started it, don't stop beta blocker. Leave that at such a low dose that you're able to control the heart failure with up titrated dose of diuretics. Now after that, again, once you achieve the dry state, again increase that increment of again 3.125 of carvedilol. So step ladder approach until you achieve 25 milligram or close to 25 milligram OD or BD. So most important thing is to start at a very low dose, to increment after 2 weeks. If patient slips in decompensated stage, then increase the dose of diuretic, but don't stop beta blocker, and try to go as high as possible. But if, for example, patient is absolutely intolerant, then leave him at least on 3.1 to 5, because again this is going to improve the patient's survival. So beta blockers that improve patient survival, ACE inhibitor improve patient survival, aldactone improve patient survival. This thing does not. Digoxin, commonly used, does not do anything.
Beta blockers should be given in every cause of heart failure or just post-myocardial infarction heart failure. For example, if the patient is asthmatic and due to pulmonary hypertension is having heart failure. So even then you prescribe beta blockers?
Right. As I said in the beginning, that heart failure is a syndrome. It's not one disease. So therefore, you have to, take into consideration the underlying disease in most patients. Now, it's impossible to basically talk about individual disease first and then heart failure. When we talk about heart failure, I'm basically talking about a patient who's a prototype, such as after myocardial infarction, such as dilated cardiomyopathy, such as patients with, valvular heart disease, end-stage valvular heart disease. So those kind of patients. But a patient with, as I said, isolated mitral stenosis would not need all these things, because there you are going to control the heart rate. So just control the heart rate, and you'll and obviously a bit of diuretic. But even if you don't give ACE inhibitor, even if you don't give aldactone, doesn't matter. Similarly with hypertrophic obstructive cardiomyopathy, right? So when we're talking about most of the patients who present with heart failure in a classical sense, the heart failure as you and I recognize from edematous state, left ventricular dysfunction, and patients who got dilated flabby heart, right? Digoxin, I think I'm running out of my time, so I'll just stop here. But just to say that digoxin, as we normally used to give digoxin as kind of thing to almost every patient with heart failure, does not have any role to play in patients with normal sinus rhythm. So a patient with normal sinus rhythm and poor left ventricular function does not going to improve because of digoxin. It's only patients with atrial fibrillation. It is still a drug of choice for patients with atrial fibrillation, heart failure. That is a drug of choice, but not for patients with normal sinus rhythm, and even if the patient's got a very poor left ventricle or patient's got congestive cardiac failure. So digoxin basically does not improve survival. It only reduces the hospital stay in patients with heart failure. That was a DIG trial. So a trial is only one trial of its kind for use of digoxin in heart failure, and it showed that there's no improvement in survival, there's no improvement in quality, except reducing the duration of hospital stay in these patients, except atrial fibrillation. I'll stop here, because rest of this cardiac transplantation is a viable form of treatment. We must remember it is available, it works like renal transplantation. Unfortunately, it's not available in Pakistan, but I think it should be becoming available in the near future. Resynchronization therapy is not a big deal. It is done in those patients who got very dilated ventricle. Now, the reason I told you this left bundle branch block with 150 milliseconds of duration is the prerequisite for putting CRT. So CRT is treatment that is given to patients who got intraventricular, not intraventricular conduction defects with widening of the QRS complex more than 130 milliseconds, mitral regurgitation, and along with everything else. But again, very expensive. Statins, again, in patients with ischemic heart disease, they should be given, and they have a role to play for those patients with ischemic heart disease. I stop here. Thank you very much for your attention.